Good morning, everyone. If I could have everyone's attention, and we'll get our seats, and then we can go ahead and get started with the next presentation. I want to try to keep us on time here so that we can get back into our rhythm, which is so essential to getting us out on time and getting our lunch break and all those other important things. So our next section is Section J, Health Conditions. This incorporates two of the newer questions for the OASIS-D. You know, and I know, like Bridget said earlier, you have been using OASIS-D since January. My big question is, how's everyone doing? How's everyone doing with it? I think that as we start rolling out these new measures, we come to learn that, ooh, wait, there might be a better way of doing things. Ooh, wait, what about this question? So what we've done is take this presentation and look at those questions that have come in, and with the idea that we could actually enhance and give you guys more information with regards to, these two measures and what we should be doing to make sure we're having accurate data collection. So just as with all the other presentations, here's your list of acronyms that you're going to be seeing in this presentation. Again, there's a reference sheet that's in your folder. And the objectives for this training have to do with describing the new assessment items in Section J, health conditions, J1800 and J1900, and applying coding instructions to accurately code the practice scenarios, and finally the case study that'll be presented tomorrow. And just as a reminder, these are the two new measures for Section J, J1800, any falls since sock rock, whichever is more recent, and then J1900, the number of falls since sock rock, whichever is more recent. And remembering that these are collected at the time points of transfer, discharge, not to inpatient facility, and death at home. And when you look at this, these are actually like look-back measures. You remember back we introduced OASIS-C, what was that, 2009, I think? Some time ago, right? We got some look-back measures back then, and now we have a few more that we're actually going to be using. And, actually gathering that data throughout the episode of care is really critical to making sure that we're actually answering J1800 and J1900 accurately. And like I said, you've been gathering data on these two measures for the last 2 months or so, right? So I'm sure some questions have come up. When we look at, has the patient had any falls since sock rock, whichever is more recent? Are we answering yes for that accurately? Or are we missing some opportunities there? And then when we look at J1900, when we're coding the number of falls since sock rock, whichever is more recent, are we using the correct code to capture those? Like I said, many questions were submitted after the last training back in November. And my goal today is to give you that training again, but to enhance it with some of those Q&As that came in. So we're going to start with J1800. Any falls since sock rock, whichever is more recent. And remember that this new OASIS-D assessment item is captured at discharge, transfer, and death at home. So I always like starting with the intent. Why are we capturing this? What are we trying to get at here? And it identifies if the patient had any witnessed or unwitnessed falls since the most recent start of care or resumption of care. And think about that. Again, this is kind of that look-back question. We're looking back throughout the episode to see if the patient had any, I'm going to call them events, right, or incidents, where you would want to capture them as a fall per the OASIS guidance. And we're going to talk a little bit more about that when we get into the definitions and those pieces. So remember, as far as a fall is concerned for these measures, it is an unintentional change in position coming to rest on the ground, floor, or onto the next lower surface, such as a bed or a chair. Okay, so they were in one position and they moved to another position unintentionally, right? There was no intention to move to that lower surface. A fall may be witnessed or unwitnessed, reported by the patient or an observer or identified when the patient is found on the floor or ground, okay? So again, this could be something that's just reported, right? And a fall is not a result of an overwhelming external force, such as when a person pushes another person. They weren't able to maintain, they wind up going down. We would not be capturing that when we're looking at J1800. You know, another piece of information out there I want to share is regarding the location of the fall. Because people think, oh, well, we're in home care, it's in the home, that's what we're looking at. We're talking about a fall no matter where it occurs. It could be, you know, as a result of an environmental condition, maybe there's some water and they slip and they fall. That is something you're going to want to look at when you're trying to figure out which falls are considered for J1800. Now, some other considerations we want to look at is an intercepted fall, right? So a definition of the intercepted fall is a fall that occurs when a patient would have fallen if he or she had not caught himself, right? Or had not been intercepted by another person. Meaning they would have fallen if that other person wasn't there to catch them, right? So in this circumstance, an intercepted fall is considered a fall for J1800. Another concept that I like to share with you guys with regards to falls is that CMS understands that challenging a patient's balance and training him or her to recover from a loss of balance is an intentional therapeutic intervention and does not consider anticipated losses of balance that occur during supervised therapeutic interventions as intercepted falls. Now, just to add on to that, okay, you know, if a fall or intercepted fall occurs as a result of other therapeutic interventions, it would be considered for J1800, okay? So an example, let's just throw an example out there. So you're out there and you're doing a tug assessment. That's that timed up and go assessment, right? And if the patient falls during that or you intercept that fall, we would still consider that for J1800, right? That's not challenging a patient's balance, right? So there's the difference. Just wanted to throw that example out there. So I think it's important always to go back to the OASIS guidance when we're looking at these new measures. And this is taken right out of that guidance, the response-specific instructions. Remember, we're going to review the home health clinical record, incident reports, and other relevant clinical documentation. An example of that is like a fall log, right? But I just want to challenge you all to think back, how are we going to collect that data to ensure accuracy? Have you guys looked at making changes in your EMR system? Have you looked at maybe creating a new form? I know people don't like forms, we have enough forms, right? But we need a way, right? We need a way to operationalize this so to ensure that we have accurate data collection. So I want you guys to think about that. How are we doing that? Are we getting all of those incidents? Are we looking at all those events and considering it? Is this an actual fall, right? And remember, you're going back through your clinical record. That's where you're going to capture that over that episode of care, right? Your incident reports. The other component of that, which I think is just as important, right, is the interview of the patient and or caregiver about the occurrence of falls. How often are you guys going out and asking about falls, right? Your clinicians, are they going out every visit and saying, hey, have you fallen, right? But how many times does that patient come, oh, no, I haven't fallen, right? Is that always accurate? No. So it's going to take a lot more than just that interview. That assessment's going to have to confirm, right? So we're going to talk a little bit more about that a little later. But again, review of the medical record and that interview, the two most important components of when you're trying to ascertain if falls should be considered. Okay. So to go back to review the coding instructions for J1800, remember you're going to code 0, no, if the patient has not had any falls since the most recent start of care, resumption of care. And you're going to code 1 yes if the patient has fallen since the most recent start of care, resumption of care, okay? Remember going back to the response-specific instructions that inform us that you're going to code falls no matter where that fall occurred. So we're making sure we're capturing all of those. And that's really going to be critical, especially when we're looking at defining how this quality measure is going to be shown up on your reports. Remember that a dash is a valid response for this item, but we really do expect that to be used in a rare occurrence. So I think now that we've reviewed the coding instructions for J1800, I'd like to go into an actual practice coding scenario. So the discharging registered nurse interviews the client record and interviews the patient and the caregiver, Mrs. K, and her daughter, Susan, determining that a single fall occurred since the most recent start of care, resumption of care. The fall is documented on a clinical note from an RN home visit in which Susan reported, okay, her mother had slipped from her wheelchair to the floor the previous day. Okay, so I want us to think about this. What are some of the key relevant pieces of information we want to pull from this scenario? I like the idea that the RN, reviews the clinical record, right, and interviews, right? We're using both of those strategies, okay? And the daughter reports that her mother slipped from her wheelchair to the floor. So how would you code J1800 any falls since start of care, resumption of care? Would it be code 0, no, or code 1, yes? And I see the responses are coming in. I'm going to give a little time for our online viewing audience to respond as well. I would like to hear from everybody when it comes to these scenarios. Okay, we got about 60 responses almost in, and everyone is resoundingly saying, yes, it is indeed a fall. So let's take a look at that correct answer. And indeed, yes, we would code this as a fall. And the scenario around that the scenario that informs that is really that piece of that unwitnessed as well as witness falls. We're going to capture both of those, right? Let's look at another practice coding scenario. This is scenario number 2. An incident report describes an event in which Mr. S appears to slip on a wet spot on the floor during a home health aide bath visit. He lost his balance and bumped into the wall, but was able to steady himself and remain standing. Okay, let's think again about some of that relevant key data, right? Right, so we see an incident report. So again, we're looking at that incident report, right? And he talks about how he lost his balance and slipped, right? But he was able to remain standing. So in this scenario, how would you code J1800 any falls since start of care, resumption of care? Would it be code 0, no? Or would it be code 1, yes? And again, get out that cell phone, start submitting your answers. I'm going to give everyone a little time to answer. I see we got a lot of great responses here. So it looks like 92% of you or so say yes, okay? Let's see what the right answer is. And indeed, it is code 1, yes. And the rationale is that this was just defined as an intercepted fall, right? And do we count those for J1800? Yes, indeed, we would. Let's do another practice coding scenario. This is coding scenario number 3, and this is where a patient is participating in balance retraining activities during a therapy visit, and the therapist is intentionally challenging the patient's balance, anticipating a loss of balance. So 2 very key concepts there, right? The patient has a loss of balance to the left due to hemiplegia, and the physical therapist provides minimal assistance to allow the patient to remain standing, right? Intercepted, right? So we got to think about some of the key concepts there. This is a therapy visit where the therapist is intentionally challenging a patient's balance and anticipating a loss of that balance. And when that patient loses her balance, the therapist adjusts, right, to keep that patient standing, okay? So how would you code J1800, any falls since start of care, resumption of care? Would it be code 0, no? Or would it be code 1, yes? Okay. Oh, wow. A lot of you feel like, no, it is no, this would not be considered a fall. We would not want to capture this on J1800. Wow, I got over 100 responses for that. I got a few that say yes, so, let's take a look at what the right answer is here. And indeed, that is code 0, no. So there's a couple pieces to this rationale. Number one, right, the patient's balance was intentionally being challenged by the physical therapist, and a loss of balance was anticipated, okay? We knew that that patient could have fallen, right, through that intervention. And then just knowing that when assistance is provided to a patient to allow him or her to maintain that standing position during an anticipated loss of balance, during that supervised therapeutic intervention, we would not consider this a fall or an intercepted fall. So it sounds like we're doing really, really well with those concepts. Nice job, guys, okay? Keep going, right? One more for this section. So J1800 practice coding scenario number 4. A patient is ambulating with a walker with the help of a physical therapist. Sounds a little similar to the last one, right? Let's keep reading. The patient stumbles and the therapist has to bear some of the patient's weight in order to prevent a fall. Sounds a lot like that last scenario. So let's talk a little bit about this. First of all, this is pretty common, right? You guys have seen this, your therapists have reported things like this? Yeah, right? So the therapist is helping the patient ambulate, right? They're monitoring her or him, I guess in the picture, right? And the patient stumbles and the therapist assists to keep the patient from falling, right? So thinking about that, how would you code J1800, any falls since start of care, resumption of care? Would it be code 0, no? Or would it be code 1, yes? Okay, we're getting some of the responses in. Okay, some of you guys feel like, no, this would definitely be something you'd want to capture. And some of you guys are saying, yeah, you would want to capture it, okay? So, what is the correct answer? And the correct answer is indeed yes. We would want to capture this on J1800. Now, the rationale's a little different here because it's a different scenario. We weren't intentionally challenging that patient's balance. This was just they were just ambulating, right? There wasn't an anticipated loss of balance, right? So the stumble wasn't anticipated, and the therapist intervened to prevent the fall, but you would consider this an intercepted fall in this scenario. And an intercepted fall is considered a fall for J1800. So how'd you guys do, okay? Okay, good. So let's look at J1900, the number of falls since start of care, resumption of care, whichever is more recent. And we're going to delve a little bit more into J1900. I know this is a little bit more of a complex measure than J1800. Yes or no is pretty easy. But now we're talking about coding a few different sub-items. So we're going to get into that a little bit more here. Okay. So again, this is the new OASIS-D item, J1900. It's completed at discharge, transfer, and death at home. And it asks the number of falls since the start of care, resumption of care, whichever is more recent. And remember, you've got the 3 boxes, and you're going to put a code in each one of those boxes. And really, now that we know that we have a fall, remember, the 1800 is your gateway question. And now that we're going to move into, because we answered yes on that, we know the patient at least had a fall, right? But now what we're really trying to determine is what was that level of injury and how many they had at those different levels of injury. And just as a reminder, you're going to put a response for each level, right? So the first level is no injury, right? B is injury except major, and C is major injury. So again, as I like to start with all of these, I want to talk about the intent. So the intent really is, again, to identify the number of falls a patient had since the most recent start of care, resumption of care, and fall-related injury. okay? Because we know our patients are out there falling on occasion, and yeah, sometimes they are sustaining an injury. We want to get an idea of what that means and how that looks. That's important quality data that we should be looking at, right? So remember, when we're looking at fall-related or injury related to a fall, any documented or reported injury that occurred as a result of or was recognized within a short period of time, hours to a few days after the fall, and it's attributed to the fall, that should be considered, right? So my question to the group here, right? Do our patients, I asked this a little earlier, do our patients always report falls accurately? We already talked about that. We asked, hey, did you have a fall since I was here last week? No, I didn't fall. I'm good. I got this, right? But can you think of a scenario where a clinician might come across an injury like, say, a bruise? Mr. Smith, where'd you get that bruise? Oh, what bruise? I don't have a bruise. I don't know, right? And then you get a call from the daughter. Hey, did mom tell you about that fall she had 3 days ago? Okay. So again, this is a scenario where you are trying to capture that data at the time of the visit. But are you always able to do that? No. So what are the processes you have in place? What are the things have you thought about doing to ensure that when that daughter calls you, you're checking that box. You're capturing that, right? Because I'm guessing you're not discharging that patient at that point. Geez, I hope maybe not, right? So you have to think about what are you doing to look back, right? To think about, well, okay, so she had a fall 3 days ago. I need to put that somewhere, right? We need to capture that to make sure that that discharging clinician, or when that patient goes back into the hospital or gets transferred, you know, that they have a place where are they going to be looking to ensure that they have that data, right? I will go back though, because I know I don't want to disregard the importance of a keen assessment and solid interviewing skills at the time of the visit to make sure. Because even if your patient says, nah, I'm good, I didn't fall, right? And yet you see that bruise, isn't that going to say, well, where'd you get that bruise? Okay, oh, I don't know, honey. Okay, so maybe that daughter could have been called at that point to say, hey, did you notice your father had this bruise? Oh, yeah, he told you about that fall he had 3 days ago, right? Oh, okay. So there's a lot to this. Even though it's these two little measures, we're spending time on this because we want to make sure that we're thinking about ways that we're actually capturing this data accurately. Does that make sense, guys? Yeah, good. Okay, so again, I want to go back to the guidance manual, and I tell you guys, this is essential, especially for these new measures. You guys are all opening your guidance manuals. It's out there, it's final, it's posted, right? So this is where you're getting this stuff. Remember, when we're reviewing the home health clinical record, incident reports, and any other relevant clinical documentation such as fall logs. We want to make that part of the strategy for accurate data collection. We're going to interview the patient and or caregiver about the occurrence of falls. I have heard agencies say, oh, well, I'll just capture that at discharge. We'll ask the patient at discharge. There can be a lot of days between start of care and discharge, right? So again, I think having accurate, timely data collection through that interview process, right? Remember, it's not just the patient you can be interviewing, as we just illustrated. Remember that if a patient has one fall that results in a bruise, a skin tear, a fractured wrist, we're going to report the 3 injuries or only one, right? Okay, just one. Which one, right? So they had one fall but 3 injuries, right? We're going to determine the number of falls, and we're going to code to the level of injury of that fall. And we're going to code no matter where the fall occurred, okay? Meaning in that scenario, what injury are we going to be coding? If the patient had multiple injuries in a single fall, you're going to code the highest level of injury, okay? So let's take a look at each of those level of injuries a little closer and the coding options for each. And remember, again, you're coding 1, right? level of injury for each fall. So we're going to start with J1900A. This is no injury. So they had a fall, but there was no injury. They may have had more than one fall, but there was no injury, right? Okay. So you're going to code 0, none if the patient had no injurious fall since the most recent start of care or resumption of care. You're going to code 1 if the patient had one non-injurious fall since the most recent start of care or resumption of care. You're going to code 2, 2 or more, if the patient had 2 or more non-injurious falls since the most recent start of care or resumption of care. And again, the dash is a valid response for this measure. Okay. And remember, you had at least one fall you're reporting on, so there's got to be something in there, right? So when we're talking about the definition of no injury, this is like no evidence of any injury noted on the assessment. No complaints of pain or injury by the patient, no change in the patient's mental status, their behavior is noted, okay, after the fall. There was nothing here, okay? Just remember, no injury doesn't mean no fall, right? I just want to make sure we clarify that piece. So when we're looking at coding instructions for J1900B, injury except major, you're going to code 0, none if the patient had no falls with injury except major since the most recent start of care, resumption of care. You're going to code 1, 1 if the patient had one fall with injury except major since the most recent start of care, resumption of care. You're going to code 2, 2 or more if the patient had 2 or more falls with injury except major since the most recent start of care, resumption of care. And again, for this submeasure, that dash is a valid response, although we would expect it to be rare.
I have a question about the dash being a valid response.
Okay?
So valid is
That you can use it for this measure.
just long as you don't leave it blank.
Yeah, usually systems won't allow you to leave it blank, yeah. Okay. So definition of injury except major examples, and again, this is not an exhaustive list. They include skin tears, lacerations, abrasions, superficial bruises, hematomas, sprains, okay? And any fall-related injury that causes the patient to complain of pain, okay? And again, I'm sure there's other examples out there. You're going to be using your clinical judgment to determine that. But let's move on to coding instructions for J1900C, major injury. You're going to code 0, none if the patient had no falls with major injury since the most recent start of care, resumption of care. You're going to code 1, 1 if the patient had one fall with major injury since the most recent start of care or resumption of care. You're going to code 2, 2 or more if the patient had 2 or more falls with major injury since the most recent start of care, resumption of care. And again, the dash is considered a valid response. And again, it's going to be rare, right? We're going to expect a rare occurrence of that dash. So examples include for major injury, bone fractures, joint dislocations, closed head injuries with altered levels of consciousness, and then like a subdural hematoma. So these are pretty major injuries that resulted in pretty major, symptomology or injuries to that patient. Now, again, this is not an exhaustive list. This is just examples of major injury. So one concept I do want to share, because this did come up now that we've kind of reviewed the different levels of injury, is that when you're coding, there were some questions about treatment that came up. And, they were like, well, what would happen if the patient had, maybe staples from a laceration instead of maybe just, a Band-Aid, right? And the thing you need to keep in mind, it's not the treatment that's going to be coding your level of injury. It has to do with the injury, right? Because injuries can be treated in all different kinds of ways. We know that, right, depending on the severity. But we have to consider just the actual injury, not the actual treatment that was applied to that injury when we're looking at how we're going to code it and which level are we going to put that patient in. So in summary, the injury does not dictate the categorization of the fall for J1900. Okay? So now with all that in mind, I think this is a good time to resume a little practice scenario, would you say? Okay, so in these scenarios, you're gonna get an opportunity to code both J1800 and J1900, and the reason being, again, J1800 is that gateway question, right? You wouldn't even be moving on to J1900 if you marked it as no. So I just wanna go back to just review that quickly. Okay, so a review of the clinical record and incident reports, and a patient and caregiver report identify that a single fall occurred since the most recent start of care resumption of care. The fall is documented on a clinical note from an RN home visit that describes the patient, Mr. R's report of a fall that occurred between visits, in which he tripped on the dog, fell against the wall, banged his elbow, sustaining a skin tear that he treated himself. This is pretty realistic too. I know I've had patients, oh, the dog, right? Okay, documentation of the RN assessment during the home visit details the healing skin tear and no other injuries or symptoms identified related to the fall. So again, I'm going to take just a couple of minutes to think a little bit about what were the key concepts we found out of this scenario, right? Number one, we're looking back, right? We're going to identify what event or incident may be captured here, right? We note that there was an event where the patient tripped on his dog, right? And as a result of that, he sustained a skin tear, which he treated himself. Okay, so these are the pertinent pieces of information. So how would you code J1800 any falls since start of care resumption of care? Would it be code 0, no? Or would it be code 1, yes? So get out your phones and start voting which one you think it is. And again, this is the gateway question that we're going to start with. So it looks like we have a lot of people saying, yes, we would be considering this a fall. Okay, good. And the answer is, yes, indeed, this is a fall. So we will be continuing on to J1900. I'm sure you guys were shocked by that, right? Okay, so how would you code J1900, number of falls since Sock Rock? I did put this image up there because I want you guys to be familiar with it. I think it's still relatively new. It's like, okay, what does this look like again? So again, you're going to enter a numeric code for into each box, A, B, or C. No box should be left empty, okay? And remember to utilize the code 0, none, if as applicable for any level of injury. So I'm just going to go ahead and give you guys a chance to do that coding. And which answer do you think reflects the correct coding for this scenario? Was it A, which is J1900A1, B0, C0? Is it B, which is A0, B0, C1? Is it C, where A is 0, B is 1, and C is 0? Or would you just enter a dash in all of the responses? Okay, I hear you guys whispering. You're so fast. Okay, so let's take a look at what the correct answer is. And indeed, it is C, where A is 0, B is 1, and C is 0. And the rationale really there was documentation of how many falls? 1, right, good. And then, did it result in an injury? Yeah, and what level of injury? Right. So exactly, it's an injury except major, because that's what a laceration would be categorized as. Okay, nice job, guys. Good. Okay, so let's look at another one. This is Mr. G. A review of the patient record, incident reports, and a patient caregiver report identified that 2 falls occurred since the most recent start of care resumption of care, and the falls are documented on the clinical note. The first describes an event in which Mr. G tripped on the bathroom rug, almost fell but caught himself on the sink, and the RN assessed and identified there was no injury. The second describes an event during which Mr. G, while coming up the basement steps with the laundry, fell against the stairs and sustained a bruise and a laceration on his left knee. Okay, so let's think about what happened in this scenario, right? There were how many events? We talked about 2 events, right? The first one where he almost fell, right, but caught himself, and that resulted in no injury. And then one where he fell against the stairs and it resulted in a bruise and a cut knee, right? So we had a little bit of an injury there. So again, like I said, we're going to start with that first question. How would you code J1800 any falls since start of care, resumption of care? Would it be code 0, no? Or would it be code 1, yes? Yeah, okay. Good. I see the responses coming in. Oh, okay, we're getting up there, good. So let's go ahead and see what the correct answer is. And the answer is indeed yes. We did absolutely have a fall, right? Okay, so let's go into J1900, the number of falls since Sock Rock for this scenario. Remember, you're going to be entering an answer in for A, B, and C. And would you code this as A1, B0, C0? Or is it A1, B1, C0? Or is it A0, B1, C0? Or would it be a dash for A, B, and C? And I see there's few different responses coming in. I noticed the ones for 1900 coming a little more slowly, but that's okay. That's right. These things you need to think about this, right? You need to think about and apply that instruction, that guidance to really code this accurately. And I see 94% think it's B, so let's take a look. What does it look like, actually? And the answer is indeed B. A would be 1, no injury, right? B would be 1, injury except major, and then C, there would be no major injury in this scenario. And the rationale, again, is that the first was an intercepted fall, which is considered a fall, but it resulted in no injury, right? That's why no injury is 1, right? And the second fall resulted in a laceration and bruising, and that would be considered an injury, but not major. So nicely done there. Okay, so let's go into another one. I think these get a little bit more complex as we move along, which I think is good. Okay, a review of the patient's record incident reports and the patient and caregiver report identify that a single fall occurred since the most recent start of care or resumption of care. The fall is documented on our incident report, which describes an event in which Mrs. J fell while walking from her bedroom to the bathroom and was transported to the emergency room via ambulance. Examination and testing revealed a skin tear on Mrs. J's left hand, bruising on both knees, and a fractured hip. Okay? So, again, a few more things in this scenario. Let's just take a look. How would you code J1800 any falls since Sock Rock? Oop. Okay, so we have yes, good. Okay, and I think I actually pushed that button a little too quickly there. So let's go ahead and go to the answer. Indeed it is yes, we would. And so then how would you code J1900, the number of falls since Sock Rock, right? You remember we're going to code for each level of injury. And would it be A0, B1, C1? Or would it be A1, B1, C0? Or would it be A0, B0, C1? Or you're going to enter a dash for all, okay? And again, responses are coming in. It looks like we've got a majority of you guys think it's just that major injury, right? Well, let's see what that answer is. And indeed, yes, we would consider A0, B0, and C1 to reflect that major injury, even though we had 3 injuries, right? 1 single fall, 3 injuries. I remember going back to the guidance, it tells us to code to the highest level of injury, right? And even, again, this happens. You know, patients do have multiple levels of injury when they have falls sometimes. And so we just want to be sure that our coding is reflecting the accurate coding of that categorization of that fall. So now that we're going to be summarizing J1800 and J1900, I just have a couple of knowledge checks I want to share with you guys just to make sure we're all on the same page with some general understanding for J1800 and J1900. And my first question has to do with what J1800 and J1900 are not completed at which of the following time points? Is it transfer, discharge, start of care, or death at home? What do you guys think? Remember, are not completed at which of the following time points? Remember, we talked about it being a look back, so there's not really a lot to look back at start of care, hint, hint. So the actual correct answer is here, start of care, resumption of care. You're only capturing J1800 and J1900 at transfer, discharge not to an inpatient facility, and death at home. Okay, and let's do another one. Which example below does not meet the definition of a fall? Okay, Mrs. T reports losing her balance while going down the stairs but catching herself on the railing to remain standing. Mrs. B's daughter reports her mother falling while walking to her mailbox, so she fell, sounds like outside maybe. Mr. W reports falling after being pushed by his roommate, or they all of them meet the definition of the fall. So let's give that some thought. Looks like we got about 60 responses, 82% think it's C. We've got a lot of people thinking they all meet the definition of a fall. So we're gonna take a look at that answer now that we've got a little over 90 responses, and the correct answer is indeed C. Mr. W reports falling after being pushed by his roommate. So let's dissect this a little bit. I want to take a little time here. Although Mr. W sustained a fall, it was the result of an overwhelming external force by his roommate pushing him, right? And this, per the guidance, does not meet the definition, or the OASIS definition of a fall. Mrs. T and Mrs. B both experienced falls, right? Ms. T would have fallen if she had not caught herself, so what is that called? An intercepted fall. Nice, nice, good. And an intercepted fall is considered a fall. And Mrs. B sustained a fall while walking to her mailbox as reported by her daughter. So it was reported, and it looks like it may have been outside. Yeah, that's still a fall. Those still both all of that meets those definitions of a fall. So yeah, we would be considering that. So the last part here I want to talk a little bit about is the application of percent of residents experiencing one or more falls with major injury. And this is from the National Quality Forum. And this is where we really want to focus in on when we're talking about what is this data going to look like after we start getting it reported on, right? So, you know, this description, it reports the percentage of quality episodes in which the patient experiences one or more falls with major injury during the home health episode. And a major injury, just to go back, our examples include bone fractures, joint dislocations, closed head injuries with altered level of consciousness, and or subdural hematomas. And again, I just want to reinforce here that that's not an exhaustive list, that's just examples. And you're going to be using your clinical judgment to, or have your clinicians use clinical judgment to, you know, figure out which category that fall fits in, okay? So to go on, this is a cross-setting quality measure that meets the requirement of the IMPACT Act of 2014. You heard Kathy talk a little bit about that IMPACT Act in the overview presentation. This is the reason this exists, right? We want to meet that requirement. It's currently adopted for calendar year 2020 for the HHQRP program, the Home Health Quality Reporting program, and the data for this measure calculation is submitted via the OASIS. So we are going to be looking at all your OASIS to determine how that measure will be calculated. And I'm going to get into that in just a minute here. Okay. The quality measure is based on data reported from J1800, which I mentioned is that gateway question, right? That asks whether the patient experienced any falls since start of care, resumption of care. And J1900, that asks for the number of falls with no injury, injury except major, and major injury. But remember that the measure itself is calculated using the data reported for J1900C, the number of falls with major injury. That's important to think about, right? And again, this measure is not risk adjustment. This is why, right? You want our data to be accurate when we're reporting it, right? We want to make sure that our clinicians all understand how are they categorizing those falls. Are they capturing them accurately? You know, it would be not a good thing if they think, oh, well, everything is a C because that's a good thing, right? Oh, gosh, no, don't do that, right? It's not a good thing. Major injury is not a good thing. But we do want to see it accurately captured, right? We want to know what our population looks like when these reports come out. So when we are actually calculating that measure, we're looking at a numerator over the denominator, and the numerator being the number of quality episodes in which the patient experienced one or more falls that resulted in major injury during the episode of care. And again, that's J1900C. And then our denominator reflects all the quality episodes that are eligible except for those that meet the exclusion. Those that meet the exclusion, what would those be, right? Let's take a look at that. For the denominator, the quality episode is excluded if one of the following is true for all of the look-back scan assessments. The occurrence of falls was not assessed, or the assessment indicates that a fall occurred and that the number of falls with major injury was not assessed. Okay, so that would be your exclusion for your denominator. In your numerator exclusions, these might look a little familiar, right? Your Medicare certified home agencies are currently required, right, to collect and submit OASIS data only for adults age 18 and over, non-maternity Medicare, and Medicaid patients who are receiving skilled home health care. So remember, that's pretty familiar. That's what you're going to see as far as the parts that are going to be excluded from that numerator. And as far as public reporting, this is really an important component here. We are going to be getting that data for home health agencies publicly reported on the CMS Home Health Compare website. As long as the agencies have at least 20 observations for the quality measure. Okay, so we're going to be looking for a good number of those. And that the actual agency has been in operation for at least 6 months. So just some things to think about if you're a relatively new agency, or maybe you have a very small census. Those are two components that we need to think about when we're trying to look to see what our data looks like, because you may not get that reported if you don't meet those components. And then just in summary, J1800, any falls since Sock Rock, and J1900, the number of falls since Sock Rock are completed at transfer, discharge, not to an inpatient facility, and death at home. Again, it's a look back. It's kind of like that look back measure. You're going to look back at the episode to see where are we and what are we doing here. Understanding that an intercepted fall is considered a fall, okay? So even though the patient may have caught themselves, or, for example, the patient, the nurse was walking the patient, the nurse caught that patient, those are still considered intercepted falls, and we would be capturing those for J1800. Falls are coded regardless of where the fall occurred. Okay, there were a number of questions that came in with regards to that concept, so I just want to make sure we're all clear. If the patient was out visiting the doctor, they were out getting lab work, they went for chemotherapy, and they had a fall, we are going to be capturing that. Why? We still own that patient. That patient belongs to us still, right? And CMS does not consider anticipated losses of balance that occurred during supervised therapeutic interventions as intercepted falls. And we did talk a little bit about that concept, about what does that mean, right? You're talking about a therapeutic intervention that the patient's balance was challenged, right? And you anticipated that fall. So we would not be actually considering that. There are 3 levels of fall-related injury: no injury, injury except major, and major injury. And we did give examples for the injury except major and the major injury. And again, I just want to impress upon you guys, those are examples. It's very clear in the guidance manual that we are using clinical judgment, right, to determine how we're going to be categorizing those falls. Okay. The application of falls quality measure was adopted for the calendar year of 2020 for the HHQRP to meet the requirement of the Impact Act. So why are we doing this? It's that, what Kathy talked about earlier, right? Standardization amongst all of the cross settings, right? So that we're all looking at same measures to see how are these patients doing in that post-acute care setting, okay? And then the report actually is going to look at falls with major injury during that home health episode. So just to remind you guys, again, that accurate coding is going to be so essential. So I know that, we have this last slide that talks about action plans. Bridget had mentioned earlier that you guys have a sheet, right, in your packet that talks about action plans. My goal today was to impart, what J1800 and J1900 is all about, but also to have you guys think about what are some things that we might need to be doing, right? To change up about how we're training our staff, to maybe look at those policies and those procedures that are gonna help inform accurate coding, right? To make sure that when our clinicians do that look back, they have accurate data to look at. You know, and again, we talked about interviews with patients and family, maybe not always accurate, but we want to try to make sure we capture that as accurately as possible. So, you know, take a couple of minutes, I think, just to jot down some ideas. I think we mentioned that tomorrow we're going to have an action planning session where we're actually going to be looking at some of this with ideas that you guys can come away with some new strategies or maybe some enhanced strategies, or basically share what are your successes in the implementation of J1800 and J1900. And so with that, I think I am going to leave you guys. Thank you so much.